Good morning, everyone. Welcome back to our third and final day of the National General Medical Oncology Summit. We're doing this in partnership with the Florida Cancer Specialists. Here are the faculty that'll be working with us today, and the co-moderators from the Florida Cancer Specialists will be joining us up here on the stage as well. Before we move forward, we have kind of a little tradition at Research to Practice, just sort of lighten things up a little bit. We have a little video we like to show, so here it is.
It's a great question, Neil.
Good question.
Really important questions.
Yeah, that's a very important question.
That's a really good question.
It's an important question.
I think it's a good question.
That's a really important question.
That's a great question.
That's a great question.
That's a good question.
That's a good question.
Thanks for the good questions.
Very good question.
It's a great question.
That's a great question.
What a great question.
That's a good question.
It's a great question.
I think that's a good question.
Great questions.
That's a very good question. Excellent question.
So we have AJ Patel from Sarasota, Florida Cancer Specialist. So AJ, your job is to get our faculty to tell you that it's a great question that you asked. I mean, everything we do in Research to Practice is just based on rounds. When I was in training, I just got so much out of being able to query our attending physicians, and we just took that and made that a theme of Research to Practice. So this morning we're going to start out talking about colorectal cancer. A lot of great things going on there. We have Dr. Chris Lieu from the University of Colorado Cancer Center. Hey, Chris. And Dr. Kowal Raghav from the MD Anderson Cancer Center in Houston. So we're going to start out taking a look at a little data, then we'll get into some cases and query our faculty a little bit. Chris is going to talk about localized colorectal cancer. Chris?
Great. Thank you so much, Dr. Love, and thank you everybody for joining early in the morning. And what better way to start the morning than to talk about non-metastatic colorectal cancer. These are my disclosures. So over the next 10 minutes, I want to discuss upcoming or available evidence regarding ctDNA-based management in early-stage colorectal cancer, and really just to discuss or to ask this question, what have the available studies told us or taught us so far about MRD testing and how to make treatment decisions based off of ctDNA testing? And then we're also going to talk about neoadjuvant checkpoint inhibition for MSI-high or deficient mismatch repair resectable colorectal cancer. And really to ask the question, should immunotherapy go first and in what setting, the neoadjuvant setting or the adjuvant setting? So I want to start out with ctDNA, and I'm going to talk briefly about the available data in stage 2, and really just focus on this Australian study, the Dynamic study, which is essentially asking this question, could ctDNA-guided management really change or impact disease-free survival for patients with stage 2 colorectal cancer? So this is patients with stage 2. It could be low risk or high risk. They are randomized in a 2-to-1 fashion to either receive ctDNA-guided management, where if they were ctDNA positive, they would get adjuvant chemotherapy, or if they were ctDNA negative, they would just proceed with observation versus standard management, which is how we typically treat stage 2 colon cancer with just essentially clinico-pathologic features. And the endpoint on this study was relapse-free survival. And what they saw were these two curves that really essentially moved together completely in parallel. And so when you look at the disease-free or recurrence-free survival, there's really no difference between the two arms. The difference was that in the ctDNA-guided management arm, it was only 15% of the patient population that received chemotherapy. Why is that important? It's because, well, standard management was roughly 30%, so essentially half the patients received chemotherapy and got exactly the same outcomes. And the reason why this study is important is because it shows that you can still achieve really great outcomes with ctDNA-guided management without a detriment in disease-free survival by using half the chemotherapy. So the take-home point really for stage 2 colon cancer is ctDNA can be considered in low-risk stage 2 colon cancer. And really the question that I want to posit to the group, and I'm sure we're going to talk about this, if ctDNA is positive, who would not offer adjuvant chemotherapy? And really maybe what I should really clarify is if ctDNA is positive and then serially positive, that's obviously a really concerning trend. And I'm going to show you data on the outcomes in those patients. So what about the data in stage 3? Now, this is what we really want to kind of figure out, is that when you look at our patients with stage 3 colon cancer, it's a one-size-fits-all treatment. You got stage 3 colon cancer, low risk or high risk. we're going to offer you somewhere between 3 months and 6 months of either FOLFOX or CAPOX. So the problem with this, as you well know, is that if we take 10 patients with stage 3 colon cancer, half of them are already cured with surgery alone, which means we're already treating them needlessly. 2 to 3 patients are going to have recurrence whether we give them chemotherapy or not. So when you do the math, we're essentially treating 10 patients to save 2 or 3. And so the question being, can ctDNA really help us either inform us to not do chemotherapy, or do patients actually need an escalation of some type of adjuvant therapy? So there's data that was recently updated at ASCO GI just this past January, utilizing this cohort, which is the bespoke CRC cohort, using a tumor-informed assay and just following these patients, either stage 1 all the way up through resected stage 4. And what the data shows, and this is really consistent across many, many studies, is that ctDNA positivity in that time period between 2 to 12 weeks after surgery, just that one test has a really, really powerful ability to predict disease-free survival. So if you're ctDNA negative, you had an incredible disease-free survival, 91% 2-year disease-free survival. But if you're ctDNA positive, you had a 30% 2-year disease-free survival. When you look at the ctDNA-based MRD testing and the use of adjuvant chemotherapy, this is a really interesting slide, and this has been proven also in the Japanese Galaxy study, that if you are MRD negative, and that's that curve on the right, you had absolutely no difference whether you got observation or adjuvant chemotherapy. Now remember, this is not a randomized clinical trial, this is just observational data, but very, very interesting that all of the benefit for adjuvant chemotherapy were in the patients that were ctDNA positive. And you still see the disease-free survival curves don't look great, but there is an improvement in those patients receiving adjuvant chemotherapy. There's also another lesson to be learned from this cohort, and that is you really have to have sustained clearance of ctDNA to achieve that really good disease-free survival. So just transient clearance seems to just delay the inevitable, and that's the red curve and the green curve. So if you only transiently clear your ctDNA, you seem to kind of push that curve out, but you can still see that the disease-free survival is quite poor. Whereas if you have sustained clearance, and that's the blue line, remember, this is not a ton of cases, but in that subset, there were no recurrences. I also want to present data from this study. The 80702 was part of the IDEA collaboration. We've talked a lot about 3 months versus 6 months of FOLFOX or CAPOX for stage 3 colon cancer, and this was part of the IDEA collaboration with CALGB 80702. Interestingly, the other part of this study was the use of celecoxib after all your therapy was complete versus placebo. So there are 2 parts to this study. And when they did ctDNA analysis of essentially the 1,000 patients or so that they were able to analyze, 81.6% were ctDNA negative, 18.4% were ctDNA positive. When you look at the survival by ctDNA status, again, this disease-free is not quite as good as what I showed you in the bespoke study, but when you look at DFS and overall survival, you can see that they did much better if they were ctDNA negative versus ctDNA positive. One of the weirder, more interesting things that came out of this study was this. And what you're looking at here is the impact of celecoxib on patients that are ctDNA positive, which is those dotted lines. And you see a separation of the curves. If you're ctDNA positive and receive celecoxib, it looks like there's a separation of the curves for both disease-free survival and overall survival in patients that were receiving celecoxib postoperatively. So this was the summary from GI ASCO. And what I'll tell you is that in the ctDNA positive arm, it didn't look like the patients that got celecoxib seemed to do better. I'm going to make the caveat, this is a subset of a subset analysis. So we have to be very careful in terms of how we interpret and utilize this data, but I think at least it's hypothesis generating. So what have these studies taught us? ctDNA is easily the most prognostic test we've ever seen. And I'm wondering at this point if ctDNA can be used in stage 2 colon cancer to escalate to chemotherapy, but I'm sure we're going to talk about that. In stage 3 colon cancer, I would say that we really do need randomized clinical control trials, and this is the Circulate North America study that's open up across the country, but also available in Canada as well, utilizing ctDNA to make treatment management decisions. I would encourage you guys to enroll onto this trial if possible, because this is the kind of data that we need.
Let me just interrupt you just for a second, if I could. We'll hold a time or two, because you went through a lot of stuff here. And while it's in everybody's mind, I want to just pick up a couple of points. Just first of all, I'm just kind of curious, AJ, are you utilizing Signatera or ctDNA in the adjuvant setting yourself?
Yes, I have used it quite a bit. I think it's super helpful. I have found that it does lead to a lot of anxiety in some situations where, if you don't prep the patient properly in terms of, what the information is going to entail and kind of preemptively discuss whether or not you're going to make management decisions before the results are back. I think that can be a difficult conversation. It's easy when it's negative, but if it's positive, I think it can be very challenging to discuss, and especially if you're not going to treat based on it. But I found it very useful. I like it in the early stage 3. I like it in the MSI high patients where you might not want to give FOLFOX.
So, Kawal, it's not an unusual thing for a general medical oncologist to say, and yet when you go to the NCCN guidelines, you go to UpToDate, it doesn't really endorse the strategy, and we have ongoing trials looking at it. I'm curious what your thoughts about the disparity, not just in general medical oncologists, but even investigators, although they'll say, a lot of them will say, well, we need to wait for the data to see if it really is going to make a difference. Any thoughts about that?
Yeah, I think the controversy reflects the fact that we don't have enough data to support this unanimously in every setting. There is a niche population in which I think this is important. We actually have a research program called the Intercept, where we are screening all patients with stage 2, stage 3 disease with ctDNA. But the purpose majorly for that is to find patients for clinical trials for MRD. I think there is a great value of ctDNA positivity post-surgery, as Chris mentioned, and Dr. Patel mentioned regarding use of it to determine eligibility for chemotherapy. Sometimes you can tailor it if patients are not tolerating their treatment well. The role in surveillance and what you do if you've already completed your definitive therapy is yet uncertain.
Yeah, I'm glad you brought up the Intercept study because I was going to ask you about it. I think it's so fascinating. It's kind of almost like to me, like a basket trial where you're looking at different types of interventions. One of them, I think, is an mRNA vaccine. Can you talk a little bit about how you're kind of triaging patients into different, new clinical trials?
Yeah, I'm glad you found that very interesting. I think it's a great platform. We do recognize that this is a very powerful tool. And as any other powerful tool, we recognize that there are nuances with it and there are use cases of this. And the major use case is once you've completed your definitive therapy, once you've done what is standard of care, and you're still ctDNA positive, the data is very clear that these patients actually have, if anything, micrometastatic disease, and they are going to recur within a year, most of them, right? This is a great window of opportunity to engage on therapeutic modalities that may not be very successful once the disease is established in the metastatic setting. For example, immunotherapy, we've seen as we take it up the lines of treatment, it is showing more and more efficacy, even sometimes in patient population, which is MSI stable. So we feel that IO would be a great option for MRD positive patients, and maybe perhaps this is the area where we could still cure the patients just like stage 3 disease. So there are multiple trials that are coming off Intercept. So if you have any patients that are ctDNA positive looking for clinical trials, that would be one of the options.
So, Chris, another thing I wanted you to flesh out a little bit more is the celecoxib thing. Given the lack of toxicity, I guess theoretically you could use aspirin as well. And of course, this has been a question for years. This has been studied, has been negative, and now you have this. So, for practical purposes, who exactly are the people that were identified there? Or should everybody think about using celecoxib as long as people tolerate it?
Yeah, that's why I wanted to present that data with a caveat, just saying, the first subset analysis that was unplanned is the ctDNA, and then the second subset of a subset analysis is the celecoxib portion of this. I think everybody in the room can't think of like a rationale of how celecoxib has significant anti-tumor activity. So that's number one, right? We kind of have to think about it scientifically. But the second thing is that there is positive aspirin data in the PIK3CA mutated patient population that gets aspirin after the completion of adjuvant therapy, and there's a survival benefit, right, seen in that. And so you start to wonder, is there an interaction there? But the problem is that we don't know because, again, it's a subset of a subset analysis. I am not recommending here that we use celecoxib in the post-operative, post-adjuvant setting, But I am saying that that is a very, very interesting finding. And it really, I mean, we need to kind of figure out biologically what's going on. But then number two, ask a better question within a clinical trial to answer that before we start using it.
Yeah, you're going to have patients coming in and ask you about it, I'm pretty sure. One other thing, and Kowal, I'm curious about, we did a webinar recently with Jeff Meyerhart from Dana-Farber, and he and that group have had a lot of interest in sort of lifestyle issues as it relates to adjuvant and metastatic disease, diet, exercise, et cetera. Any thoughts about that data, any mechanisms that might be involved? And I'm kind of curious, do you advise your patients as they say, is there anything else I can do to maybe increase my risk? Do you bring this up?
Yeah, I mean, I think, Chris pointed this out very well. I mean, this is not the first time we've seen a subgroup analysis fall through the cracks, right? There was just recently, there was a subgroup analysis of the TRIBE study where we found that triplet cytotoxic may be better for BRAF V600E mutant patients. But when the more definitive study was done, that difference sort of went away. So I'd be very careful about over-interpreting analysis. That said, it's very hard to do lifestyle studies. It's very hard to do these treatments. And whenever I talk to my patients, I always tell them to adopt a good, healthy lifestyle, which is a good thing whether you have cancer or not. And anything that is not very expensive or will cause unnecessary burden to patients. Of course, I won't tell them to start doing hot yoga 5 times a week to reduce their colorectal. But I think, being generally active, having a balanced diet, taking aspirin if it's indicated for any other condition, I think is very reasonable. But I always tell them that there is a caveat to whatever data we are presenting, and there is no strong randomized evidence that celecoxib works in these patients. And I think we need the onus is on us to generate that.
So let's move on and get back to Chris's talk, and you're about to talk about the use of immune checkpoint inhibitors in patients with MSI-high disease. And as you listen to this, I'd like you to think about the question of, are we getting MSI testing prior to patients getting local therapy nowadays, and do we need to? I don't know. I would assume this is being done, I don't know, AJ, or do you think that in patients with rectal cancer, before they have a treatment plan, are having MSI testing?
At least locally, I think it's near 100%. I think whether they get the biopsy at the hospital or at an outpatient endoscopy center, almost all places are doing reflex, at least IHC. I don't think that you'll have genetic testing in terms of MSI-high testing, but most centers, as far as I know, do the MSI-high testing by immunohistochemistry on the biopsy specimen.
So, I mean, that doesn't,
I'm
I'm gratified to hear that. It doesn't tremendously surprise me, but I'm also curious, and you're going to see some pretty interesting data on colon cancer. I'm assuming that people aren't getting, or are they also getting?
No, they are.
Really?
As well, as far as I've seen. Yeah, by IHC. And then usually the resection specimen, most of the time, isn't tested again if the biopsy specimen was tested by IHC.
All right, Chris, so let's take a look. I was bringing this up to the GYN people yesterday and saying, what about MSI-high endometrial cancer? I don't even think they're studying it yet, but anyhow, let's see what we know in terms of colorectal cancer.
Absolutely. I think it's a great point, and certainly as you look at this data, we need to think about when medical oncology starts interacting with these patients, and I think that's going to become increasingly important as the testing rates obviously improve and we get this data, but also when we might be able to intervene on these patients. So, this was the trial that led to about 1,000 different calls to my clinic about dostarlimab when the New York Times reported on it. But this was dostarlimab for MSI-high stage 2 and 3 rectal cancer. Very simple design. Dostarlimab for 6 months. If they had complete clinical response, they went on to watch and wait. If they had residual disease, then they're going to move on to potentially surgery after chemoradiation. But of course, this was what made all the headlines, and that there was 100% complete clinical response in the 42 patients that completed dostarlimab without any evidence of any grade 3 or 4 toxicities, although we all know that immunotherapy does have a significant toxicity rate. The main take-home point from this was the question being, is neoadjuvant immune checkpoint inhibition ready for prime time? And NCCN does think so, right? That their preferred regimen is to go ahead and start with 6 months of immunotherapy and see if there's a response. Well, the questions that kind of come after this is, well, what about stage 1 rectal cancer? What if it's low or high? Should we be, we've seen a lot of data with single agent. Should we be using dual agent? One of the big questions that the FDA has really been trying to answer is, does path CR mean that you're cured? And then that has a direct correlation with disease-free survival and overall survival. This data is still very immature, and I'm not sure that we totally know the answer, but it looks like the answer is going to be yes. And then obviously there's a lot of data that's now coming out looking at immune inhibition and even our microsatellite stable patients, and Dr. Raghav had mentioned this, that we're starting to see, at least some responses to immunotherapy in earlier stage colorectal cancer. So that's also a very interesting finding. Now, certainly there's additional data that's going to be coming out. This is the AZUR-1 study. Again, asking a similar question, right? If there's 6 months of dostarlimab, and then the tumor assessment at 6 months, if there's a complete clinical response, then they follow with non-operative management. But if there's residual disease, then they move on to standard of care therapy. So hopefully, and there are a lot of trials that are like this that are ongoing, so hopefully we'll get more data in the future. So Dr. Love had also mentioned colon cancer. This is the European Niche 2 study looking at a very small dose of immunotherapy prior to an operation. So they essentially got 1 dose of ipilimumab, 2 doses of nivolumab separated by 2 weeks, and then they went on to surgery. So this is not a ton of therapy before going on to colon cancer surgery. 95% of these patients had a major pathologic response. 67% had a pathologic complete response rate. And when you look at the 3-year disease-free survival, and this was just presented in September at ESMO 2024, 100% 3-year disease-free survival. I'll also make mention that of all of these patients, only 3 received adjuvant chemotherapy. So all this disease-free survival is driven essentially by 1 dose of ipi and 2 doses of nivolumab. And so the question really being, to the point that was already raised, well, are medical oncologists seeing these patients before they go to surgery? Or are you seeing them after they have surgery, and then you got to figure out what to do with those patients? So some of the take-home points here for NCCN, they're saying that neoadjuvant immune checkpoint inhibition should be considered for high-risk disease, T4B, bulky nodal disease. And so the question being, well, if you're going to have these incredible responses to neoadjuvant immunotherapy, could you consider non-operative management for colon cancer? But that's a very, very complex question, right? Because we're no longer doing flexible sigmoidoscopies to look for rectal cancer. You're asking these patients to undergo full colonoscopies. Are serial colonoscopies better or worse than a hemicolectomy? What's the best duration of immunotherapy? Niche only used essentially 1 month of immunotherapy. And what about adjuvant therapy in this setting? So the AZUR-2 study is really trying to answer the question, can we just get away with immunotherapy for colon cancer? Here, the patients with resectable high-risk stage 2 or stage 3 colon cancer going to receive dostarlimab surgery and dostarlimab versus standard of care surgery and chemotherapy. And then I will tell you that this is a study that we've all been waiting for some time. This is a post-operative adjuvant immunotherapy where patients with stage 3 disease, MSI high, are supposed to get FOLFOX or FOLFOX and atezo. This completed enrollment at 2023, and you will see this data at ASCO in June. And so we'll move on to the questions, but thank you guys very much.
So just to pick up on a few of the things that you were getting into there, I guess one thing I wonder about Koal is patients who get neoadjuvant IO and have an autoimmune complication and then surgery gets delayed. Do you know how often that occurs?
Yeah, so it's hard to know. If you look at published literature, you'd feel as if IO has no toxicities whatsoever, but the reality is they do have toxicities. Fortunately, though, as Chris pointed out, even a few cycles of IO, and if we have to interrupt them because of toxicities, can sometimes lead to pathological responses. So I had a patient who had immunotherapy on a clinical trial for neoadjuvant setting and developed autoimmune hemolytic anemia after 1 cycle. And the treatment was the surgery was delayed by 3 months. And when they went in, the patient had a pathological complete response and still is disease-free. So I do think that despite the toxicity associated with it, the amount of benefit in MSI high disease justifies the use of this, especially when there is a high risk for surgery or the surgery is a high morbid surgery, such as something that would require an ostomy and others.
Sort of a related question, Chris, and I'm curious, AJ, what you see in your clinical practice, particularly in a patient with rectal cancer, where there's so much excitement about dostarlimab and IO, a history of prior autoimmune disease. I'm curious, AJ, what kinds of things you see in your practice and how you think through whether to use immunotherapy, particularly in an MSI high patient.
Sure. So I guess I would try to get a sense of the severity of their autoimmune disease, whether it's mild, ectopic sort of skin issues, or if they have, a history of lupus nephritis. That would be, I think, significant for me. For those that have pretty mild disease, single agent immunotherapy is generally what I lean towards. If they have severe autoimmune disease, I generally shy away from immunotherapy. Definitely the doublet, I think, frightens me enough to avoid if they have more than just a mild case of an autoimmune condition.
So we got a bunch of great questions from the audience as well. Michael, who's here this morning, wants to know, in terms of the INTERCEPT trial that we're talking about, do you take people who have resected colon, mets to the liver?
Yeah.
Do you use ctDNA clinically in those patients, even outside of a trial?
Yeah, so we believe MRD is MRD, depending on whether it is stage 2, stage 3, or stage 4 disease. So INTERCEPT platform allows enrollment of all patients who have definitively completed treatment and have radiographically no evidence of disease.
If I could ask a question about it, are there certain sites where the metastatic sites would change your opinion about that? For example, peritoneal disease may or may not, I think, may not have as much ctDNA positivity?
I knew you would ask that question. I think that's a very nuanced question. There is some data that the sensitivity of ctDNA depends on site of metastases. Lung metastases generally tend to have less ctDNA sensitivity. But I think we are learning that, Krish. Like we don't really know exactly how to deal with this. But as has been pointed out, the question is, if you're ctDNA positive, then you have a much more better way of knowing what to do with the patient. If you're ctDNA negative, you can't just be rest assured that things will not change. Although there is some research ongoing in trying to predict the site of metastases from your signatures, right? So that is something that would be out in the future and is promising.
So one more question from Hassan. Chris, it was a great question. How are you treating stage 3 MSI high disease outside a trial?
Yeah, I think that one of the most common things that we get on our end is a patient that has surgery and has the testing, then they show up into your office, they have stage 3 MSI high. And I think that that's a really difficult situation because you're going to give them FOLFOX or CAPOX. That's the answer. And I think that we'll see if that changes in June, because we may be adding in immunotherapy, but you don't have the data to make that decision. I think really this kind of proves that we have to have a discussion with our surgical teams about, number one, ensuring that the testing is done prior to surgery, and then number two, if they're MSI high, to have that multidisciplinary conversation, because what if you do give them a dose or two of immunotherapy prior to surgery? Because then you may be in a situation where you don't give any adjuvant therapy at all. I just want to make this point very clear. In a niche 2 study, 3 patients got adjuvant chemotherapy, and they really were enriched for stage 2, stage 3 colon cancer, which means that 100% disease-free survival was driven completely by surgery and by immunotherapy. And we should really be encountering these patients prior to surgery just so we can have that discussion, because the worst case scenario currently from now until June is going to be stage 3, MSI high, and you see them on the back end and they have 5 lymph nodes positive, you're going to give them chemotherapy. But we have even concerns about the effectiveness of chemotherapy in this patient population.
All right, we're going to move on now and talk about metastatic disease. And before we get into some of the data, we're going to go through a case that AJ has of a 46-year-old man. Can you talk about him?
Yeah, sure. So the question here was about consolidation therapy after primary chemotherapy. So this is a mid-40s, healthy-year-old male, presents with de novo metastatic rectal cancer, predominantly hepatic metastatic disease, has multifocal disease, bilobar, single dominant lesion on the right, scattered lesions on the left. He had primary rectal, so he was given with FOLFIRINOX bev for 6 months, had a great response, resolution of the rectal lesion, improvement of the liver, still 1 residual lesion, about 2 centimeters big. So one question about this is consolidation. Is there actual data for consolidation that there's an extension of life, or Is this something that a lot of us pursue in terms of the patient really desiring surgery, the catharsis of having some sort of removal of tumor? And then on top of this patient had a V600K BRAF mutation, so he was not given targeted therapy as these studies weren't available, and that's a less common mutation. So I'm wondering if that mutation would be something that you guys would consider doing targeted therapy for if he was presenting now with metastatic disease.
Chris?
Yeah, so I think a lot of times these patients actually do go on to surgery. The concern I think there is that there's obviously residual micrometastatic disease. This could be a situation where you may want to utilize ctDNA. It may just provide you with additional information. But I think, at our institutions, a lot of times these patients do go on to surgery. There's actually a clinical trial trying to answer this question called the Erasure study, which is a cooperative groups trial trying to figure out, do patients really truly benefit from these ablative therapies or sometimes even surgical resection. But I think that, with our patients, especially when they have a tremendous response to chemotherapy, we want to give them the benefit of the doubt to see if we can clear their metastatic disease, even though that the recurrence risk is going to be quite high.
Manuel, what about targeted therapy in a patient with V600K?
Yeah, I think, you're just throwing curveballs my side. BRAF V600K mutation. So first of all, we don't have any approvals in sort of any adjuvant setting. So if this patient got surgery, I think, that would be the best. Like, if you can always cytoreduce disease based on surgery, I think there is some benefit to that, no matter, even if it is a chemotherapy-free benefit. But let's say the patient does have metastatic disease and you want to consolidate with a BRAF therapy. Most of the data in colorectal cancer is for BRAF V600E mutations. And actually, if you think about it, nearly of all the mutations in colorectal cancer, I would say about 80% of those would be BRAF V600, which are the class 1. Class 1s are the ones that are more aggressive, they're active, and they may respond to BRAF inhibition. But out of that, only about maybe 10% would be like BRAF V600K. Now, there's no data in colorectal cancer directly, but there is data in melanoma that encorafenib and binimetinib will work in that population. We usually try to put these patients on non-BRAF V600E trials. We do actually have trials for BRAF class 2, class 3 BRAF agents. But if the patient is progressing, I would give him a trial of a BRAF therapy. And again, coming to the surgery point, you have to think about the natural course of this disease because you also have a BRAF V600 mutation, which generally gives you a more aggressive disease and poor prognosis.
All right, let's take a look at some data.
All right. Thanks, Chris, for getting us warmed up. I'm going to go through 6 different important and impactful subsets of colorectal cancer. It's going to seem something like Sonic, which my little girl watches. So bear with me. We're going to start with...
It's the whole weekend here.
These are usually full sessions at ASCO and GI ASCO. So here's our marathon. So these are my disclosures. We're going to go over a bunch of trials. This is Keynote 177 long-term results. All of you are already aware of the Keynote 177 study. This was a study in MSI-high colorectal cancer. It's important because it's a study that established immunotherapy as the first-line treatment for metastatic colorectal cancer. These were all MSI-high tumors, locally tested, had not received prior treatment, randomized to pembro and standard of care, which was chemo, at that time with a dual primary endpoint of PFS and OS. You can see this was the first results that were primary analysis that were presented. It showed doubling of the PFS from 8 months to 17 months median PFS with response rate that changed from 33 to 43%. So on the looks of it, it seems like the response rate has only increased by 10%, but you can see the tail of that curve, which takes you through the fact that these are very, very durable responses. The second results of this was the final analysis that was presented, and they looked at overall survival, and you can see statistically speaking that overall survival did not meet its primary endpoint, but this was also primarily because 36% in the chemotherapy group met crossover criteria and got pembrolizumab. Another 24% received anti-PD-1 or anti-PD-L1 therapy off protocol, and then 4% of the patients that were assigned to chemotherapy did not actually take it. So if you think about it, nearly 70% of patients on chemotherapy actually got IO in second-line setting, which means that IO is a very effective option even if you missed it on your initiation of treatment. So if you start with treatment and you find an MSI high tumor, even if you've started chemotherapy, I would switch them. And then you can see that the grade 3 toxicity were definitely less, so it's a better option. This is sort of like the updated 5-year follow-up, and you can see progression-free survival, overall survival, and the duration of response is dramatically better for patients who got pembrolizumab as single agent over standard of treatment, including overall survival benefit. So I think that this study has conclusively proved that IO is the first-line option for patients in metastatic setting. This brings us to checkmate HW. Now we know that IO should be used. It's single-agent IO. What happens with immune checkpoints? So this study was based on the fact that when you compare the curves of pembrolizumab in Keynote 177 and some of the non-randomized trial of dual immune checkpoint inhibition with Nivo and Ipi, you can see the curves look much, much better. The median OS and the median PFS at 24 months is like 73%, 78% respectively. So this brought about the checkmate 8HW study. This was a randomized study of Nivo-Ipi against standard of care in 2:2:1 randomization with PFS being the primary endpoint. And this is the data comparing Nivo and Nivo-Ipi, and you can see that Nivo-Ipi was better with a 36 months progression-free survival rate of 68% compared to 51%. This study should also be, another mention should be made of the comparison with chemo. It is definitely better than chemo, whether you take Nivo-Ipi or Nivo. And the response rates are clearly better with IO. Dual immune checkpoint, of course, comes with a slightly higher degree of grade 3 toxicities. Going on to Breakwater trial, this is the next subset of colorectal cancer, the BRAF V600E mutant colorectal cancer. The primary analysis of this was based on the premise that when you look at the TRIBE2 study, despite intensification of chemo, the red curves that you see are the BRAF patients that either got dual cytotoxic or triplet cytotoxic. Their median OS is actually worse than the median OS seen with garden variety colorectal cancer, which is non-BRAF V600E. And we already know the results of the Beacon study, which established BRAF as a second-line treatment, which showed benefit of survival about 5.4 to 8.4 months. So we know that BRAF therapy works and chemotherapy doesn't work in this subset. So the question was, if you bring BRAF up front and add it to chemotherapy, can you bring about better responses? And this is where the Breakwater study comes in. The study's only primary, and there were two primary endpoints, PFS and objective response rate, and objective response rate has been reported. The study was actually a 3-arm study with BRAF plus chemo versus standard of care, which was chemo. We are only going to see the difference of BRAF plus chemo versus chemo because the BRAF-only therapy was stopped early on. So you can see that the response rates changed from about 40% to 60%. And the confirmed objective response rate was definitely better and statistically significant. The duration of response was also much better in these patients. It was 5 months for chemotherapy arms. So these patients sometimes respond, they just don't respond for a long period of time. And 15 months for the BRAF therapy. This is the overall survival curves, and you can see again, just like immunotherapy, we are starting to see tail of the curve with patients having long-term responses and outcomes in this setting. Grade 3 or 4 toxicities were more for the BRAF combination. This is 70% compared to 54% because you're adding something to chemo. But clearly, there is a survival benefit and a response rate benefit. We're still waiting for the data to mature. The only thing to remember in this study is that not all patients that progressed on chemo actually got to BRAF therapy, and the reasons for that need to be elucidated. If it was because of lack of access, then it's a very different thing. But if it is that truly these patients fall off and are not able to get second-line treatment, then this should be adopted in first-line, period. Coming to anti-HER2 therapies, I'm going to go through 3 different trials really quickly. This is trastuzumab tucatinib. This is a pivotal trial that laid the foundation of the first approval of a HER2 therapy in colorectal cancer. This was a non-randomized, it was initially a non-randomized single-arm study, which was later on randomized, but it was a non-comparative randomization. So patients got trastuzumab tucatinib over tucatinib. All of these patients were HER2 positive, and they were RAS wild type. Remember that dual anti-HER2 inhibition does not work in RAS mutant patients that have HER2 amplification. This is a small proportion of patients. You can see clearly the response rates of about 40% or so, and that response rate is enriched in patients that have HER2 3+ IHC, i.e. higher level of amplifications. You can also see that this works better in left-sided disease than right-sided disease. And more importantly, tucatinib monotherapy only had a response rate of about 3%. So unlike breast cancer, there is no role for single-agent anti-HER2 therapy in colorectal cancer. These patients should be treated with dual anti-HER2 therapy. Trastuzumab deruxtecan is the next kid on the block. This is an antibody-drug conjugate. Many of you are aware of it because of approvals in lung cancer and breast cancer. This was Destiny CRC02 study. The notable difference here was this study allowed RAS mutant and RAS wild-type patients, and the reason for that is the antibody-drug conjugate doesn't matter whether it is dependent on HER2 signaling or not. This was also a comparative arm, but it was a comparison of 2 different doses because 6.4 milligrams was already seen to be efficacious in colorectal cancer. The study showed a response rate of about 38% in the 5.4 milligram per dose arm with reasonable safety profile. But more importantly, these drugs worked despite the presence of prior anti-HER2 therapy. And they, again, work mostly in patients that have HER2 3+ tumors rather than 2+ tumors. This is SWOG 1613. This was a randomized trial comparing trastuzumab pertuzumab to cetuximab-based treatment. There is some data that HER2 amplified patients do not respond as well to anti-EGFR therapies. And the overall analysis of this study showed us that there is an interaction effect between the level of amplification and the amount of benefit that you would get from HER2 therapy versus anti-EGFR therapy. If your HER2 amplification is really high, anti-HER2 therapy works better. If it's low, anti-EGFR therapy may have benefit in these patients. KRAS 12C therapy, this is some of the data that we are showing regarding Crystal-1, which is adagrasib. This was randomization. This was not randomized, but 2 cohorts, adagrasib and adagrasib cetuximab. And this study proved conclusively that unlike other tumors, single-agent KRAS inhibition does not work in colorectal cancer patients. You can see that the overall response rate was only about 10% with monotherapy, whereas it was, 23%, whereas it was 46% with adagrasib plus cetuximab, and the updated analysis confirmed that. The second one was CodeBreak 300. This was sotorasib, and this was combination of 2 doses of sotorasib with anti-EGFR compared to standard of care, which actually showed that the higher doses of sotorasib led to better progression-free survival compared to lower doses, but both those doses in combination with anti-EGFR did better than standard of care, regorafenib or Bev-TAS. So this has laid the foundation of KRAS 12C inhibitor along with anti-EGFR being the standard of care currently in treatment-refractory colorectal cancer. Last but not the least, this is the FRESCO-2 study. FRESCO-2 study is fruquintinib compared to placebo. This was patients that were highly treatment-refractory. It was based on FRESCO-1 study wherein only about 30% of patients had prior VEGF inhibition. So when they did the FRESCO-2 study, they made treatment with anti-VEGF important, and you can see 96% of these patients had prior VEGF, and despite that, giving fruquintinib over placebo led to a survival benefit in these patients. This is, it's a cytostatic agent. There are no responses, and you can see that hypertension grade 3 can occur in 14% of patients. But despite all of this, this is a standard of care in a highly treatment refractory population. And I'll stop there and see if we have any questions.
So yeah, a bunch of questions coming in. Chris, Shobha has a patient who had a significant flare of psoriasis on the checkpoint inhibitor. The question is about whether low-dose prednisone is safe in a patient, or does it interfere with the effects of checkpoint inhibitors?
Yeah, this is certainly an area of significant debate. I think in this situation, you still want to give the patient every opportunity to receive the immunotherapy based off of the data that Dr. Raghav showed. And I think here, even with a low dose amount of steroid, you do have a little bit concerned that you're going to have less, efficacy with the immunotherapy, but I think it would be very reasonable to try.
So Albina brings up the issue, I guess it's a patient, MSI not high, but pol E. How do you manage those patients?
I think, with this, if you look at the NCCN guidelines, it's there, right? But I think the caveat is that you also want to check a tumor mutational burden, and you want to make sure that that's the hypermutated phenotype. What is a hypermutated phenotype? They define it as a TMB, usually greater than 50, right? And so that's a high number. But if you have the combination of those two, I think it'd be very reasonable to try.
So Canwell, yesterday I was kind of joking that every time we talk about a new data set that's practice changing, I'm going to ring a bell up here. Should I be ringing a bell about breakwater?
Yes, I think that this is a big moment in colorectal cancer. BRAF V600E patients, we've all shared them. They have extremely aggressive disease. And the amount of benefit that we are seeing up front with addition of BRAF to chemotherapy is much beyond what we've seen with BRAF in second line. So I do think that this is a bell moment. It also highlights a challenge that we are going to face as a medical oncologist in colorectal cancer. Because unlike lung cancer, we have always started with first-line chemotherapy in colorectal cancer without actually waiting for results like MSI or BRAF. And I think that this has brought us to a watershed moment where, as medical oncologists, we have to expedite testing of these patients as soon as metastatic disease is diagnosed.
So I guess another question, and actually very briefly, AJ, maybe you can bring up your 55-year-old lady who I guess looks like she's HER2 positive. Before you ask about this case, just curious, Chris, how do you decide in a patient who's RAS wild type, how do you decide between TDXD and tucatinib trastuzumab?
This is a situation that comes up a lot as long as they're KRAS wild type, HER2 positive. And what we mean by that, and I think Dr. Raghav made such a great point, it's got to be 3+, right? A lot of times we start with a doublet therapy. Trastuzumab tucatinib is the one that's had accelerated approval through the FDA. And the reason why we start with that is because there isn't data for the other way around, to start with trastuzumab deruxtecan and then to move to a doublet. We don't have that data. But interestingly, we do have that data for trastuzumab deruxtecan after patients had received anti-HER2 therapy. When you look at the Destiny CRC01 study, around 40% of those patients had prior anti-HER2 therapy, and they still had responses in line with what they saw in the study. And so because of that, we typically start with a doublet, and then we move on to trastuzumab deruxtecan.
So AJ, without going through the whole case here, it looks like this lady is actually getting tucatinib trastuzumab right now. And your question maybe, I guess, is about what's next?
Yeah, sure. So two questions about this case would be HER2 heterogeneity. So she was somebody who opted not to have adjuvant treatment for early stage 3 disease, ultimately had testing on that showed she was 3+ HER2. Ultimately, in the metastatic setting, rebiopsy showed HER2 2+. So one question is utility of biopsies in a repetitive fashion, and is that done in your practice would be one of the questions there. The other question is, do you guys see targeted therapy in the adjuvant setting coming to colorectal cancer in the next decade? It seems like we're way behind other fields when it comes to targeted adjuvant therapy, breast, lung. These seem like opportunities that really should be pursued in high-risk stage 3 patients, for example.
Chris?
Yeah, so, with trastuzumab tucatinib or the doublet regimens, I think that initial biopsy is totally fine. to utilize. With trastuzumab deruxtecan, because we believe that you just have to have some amount of expression, I think that that's reasonable to move on after the doublet. And to your question about adjuvant therapies, I agree. I think we're very, very behind. I think that this is maybe a situation where we compare the ctDNA testing that we talked about along with some of these adjuvant therapies, and for two reasons. Number one, it may give us a patient population to highlight that's obviously at the biggest risk for progression. But then the second step would be it's possible that these targeted therapies are simply more effective, definitely the immunotherapies, when there's less burden of disease.
All right, we're going to move on now. Thank you so much.
Thank you.